Good morning and happy Friday, and welcome to Palliative Care Friday Chalk Talk. My name is Patrice Fidel. I am your moderator for today. Today I have the pleasure of introducing Johann Friedgren, who is a physician and a PhD student at Karolinska Institute, Department of Neurobiology, Care Sciences, and Society Division of Clinical Geriatrics. He is a specialist in general and palliative medicine. He is a senior consultant at Stockholm's largest palliative care unit, a board member of Swedish Society of Palliative Medicine. He's married with two teenage kids, big soccer fan, but also sadly a Cubs fan. And he is here to talk to us about malignant ascites as a predictor of imminent death. So thank you for being with us today, and I will mute and let you have the floor.
Thank you very much, Patrice, and thank you for inviting me to this. And pardon me for being a Cubs fan, but you have to bear with me for today.
We forgive you.
At least.
Stop the call.
Thank you
Forgives you.
So, do you see my presentation now? Or, yep, great. So, I'm delighted to be here today to talk about my recent study. I have an agenda for today, small, brief presentation and a short background, and we'll talk about the article and what's next for me, and we'll end with some questions if you have them. And I have no financial conflict of interest for this. So, Patrice already said who I am. I'm 51 years old, living in south of Stockholm, and I work, as she said, at AICH Stockholm South. AICH is an abbreviation for Advanced Care in Homes, so to speak. And we do not only have palliative patients. We do have other patients with have medical needs for 24/7 medical in their homes. But most of our patients are in the palliative phase of their disease trajectory. And I would like to thank my professor here, Principal Supervisor Linda Björkenberg, which sadly couldn't attend to this today, but she sends her regards. So this is a summary of my PhD projects, and we'll talk about the first of my papers. As you can see, the mostly of my PhD project is about POCUS in palliative care, and then mainly about strategies to manage paracentesis and malignant ascites. And just to small recap of peritoneal fluid, because you all know this, but all of my patients that I meet that needs paracentesis, they always ask, where did this fluid come from, and is it for good, is it for bad? And I try to explain to them how this is the main thing about the fluid in the abdomen cavity, and that is as long as it's not to extend volume, it's only for good. And I'm very telling them that the fluid itself is not a danger. It's only a matter of symptom relief to take it away if they have problems with it. And just to pinpoint this out, that there's a difference between benign ascites or medical ascites, which is mostly through portal hypertension, hypertension in liver disease, and also in thromboembolism, but also in chronic kidney disease and congestive heart failure. However, this paper is about malignant ascites, which is quite different pathophysiology with mostly peritoneal carcinosis and the corresponding inflammation in the peritoneal tissues, which gives the excess fluid, but also lymph node obstruction because of the tumors, and of course hypoalbuminemia. Hard, difficult word to say. Hypoalbuminemia. Yeah. So this is the paper that I was invited to talk to you about, where we we thought about this malignant ascites and how if it could be used to project or predict the if imminent death in patients with advanced cancer. So Peter Strang, which is a senior professor in Sweden in palliative medicine, he had the access to this large database, the VAL database, which is a large database which contains all consumed healthcare in the Stockholm region. And Stockholm is the capital of Sweden, as many of you know, and we have about 2 million people living here, so it's a quite large database. And for this study, we had the possibility to use data from 2015 to 2021, and this contained over 118,000 deaths, and from those, approximately 20% were dying from advanced cancer. And then we tried to sort out which patients were to include, and we ended up with 1,847 patients with advanced cancer that had underwent paracentesis the last year of life. And there were available socio-demographic data. I'm not going to bore you with that, but the total cohort was 1,847 patients, and we tried to sort out all the different cancer types in these patients, and these are listed here in the whiskey blot, and you can see the boxes to the left, which has the most of the percentages made in the early of this last year, which is appendiceal cancer, quite uncommon cancer type with only 11 cases during this year. But they often present with ascites as the main symptom when they're diagnosed with the cancer. And to the right are those with paracentesis performed near to death, and with hepatocellular cancer as the most to the far right. And you can see that most cases are in the light yellow, fourth from the right. The pancreatic cancer is 299 cases, and the most common cancer type in Sweden, lung cancer, were very, very few. It's only 52 cases. And as all of you know, the malignant ascites appear mostly in gastrointestinal cancer types, and we were interested to see if there was any difference between the frequency of paracentesis if you compare ovarian cancer, which quite similar to appendiceal cancer, is cancer type that often present with ascites as to precede the diagnosis. And in the other hand, the gastrointestinal cancers, both upper and lower, where it seems that the malignant ascites appear more late in the trajectory. And we could see a difference here. There was a significant difference between if you when we compared ovarian cancer to lower GI and correspond on the ovarian to upper GI. And in Sweden Cancer Care, we put all in the upper GI. We include not only esophagus and the gastric cancer and the small bowel. We also include the bile duct, gallbladder, hepatocellular cancer, and pancreatic cancer. So it's a big group of cancer patients, and we could see a different, significant difference here. So the main outcomes of this study was that we could show that in 8% of all cases, there was a paracentesis performed in the last year of life. As many as 58% had the last paracentesis in the last month before death, and surprisingly, 25% had the last paracentesis in the last week before death. And you could ask yourself if these patients really could benefit from this paracentesis. Appendiceal cancer, as I said, there were as many as 38% of these patients had a paracentesis performed, but there were very few. And in ovarian cancer, there were also a high amount for 35%, and quite many, 210 subjects. And but the most paracentesis were performed in pancreatic cancer, which was 17% of all patients dying from pancreatic cancer in this cohort. So before I come to take home, I could maybe address some limitations to this study. That the VAL database is, as I said, contains all consumed healthcare. And to pinpoint out which patients had been subject for paracentesis, when you are admitted to a hospital, for the hospitals to get paid for what they do, we use certain classification codes in Sweden, which are mandatory to get the economic funds for the care. Many of patients in palliative care in Stockholm they are being taken care of in the kind of work I do in the outpatient clinics. In these clinics, the classification codes are not mandatory, so we will miss a very large amount of paracentesis made in the last year of life. However, it is a quite large cohort, so we think it's quite interesting due to this limitation to be able to present this. Earlier studies made similar to this have been very much smaller cohorts. So a small take-home message for this is when they present with malignant ascites that needs to be taken care of with paracentesis, it's usually a sign that death is approaching within the coming month, especially then in upper GI cancer. But as I showed, that for appendiceal cancers and ovarian cancers, this is less useful tool as a predictor. And that is all I have to show you today.
Thank you. Marty, do you have some questions you wanted to ask?
I do. I've got two. So my first one is when I was looking at your study, what I enjoyed the most was your figure 2, that whisker plot.
Yeah.
Because even though malignant ascites is a very poor prognostic factor, it also shows that there's quite a wide range, right? Yes, most people fall into that short months, maybe even less if it's something like pancreatic cancer.
Yeah.
And yet, wide range. So there's humility too in this prognostication. I how do you talk to patients about knowing that this is a poor prognostic factor, but also incorporating that humility because maybe the person you're talking to, they're not going to be the mean, right? They're an individual and they're going to have perhaps many, many months and they could be an outlier.
Yeah, that's a good question. Um, well, I don't think I addressed that, at least not when I do the first prosthesis,
Mm.
because then you really don't know what is the frequency of the prosthesis going to be,
Hmm.
and especially right according to this figure two, especially when it comes to ovarian cancer. Um, I do. I insert Pertex catheters on my patients when they have when there's a need to frequent paracentesis. And when I started with this, I did it quite often in ovarian cancers. But this has changed because when you saw the study, you can see that they probably live longer, and they have a longer period of time when receiving both adjuvant oncologic treatments as well as palliative oncologic treatment. And if they, in my opinion, these patients, they often the frequency of paracentesis decreases quite often. So yeah, you have to address it with humility to really think about it in every case. Yeah, that's right. Mm.
Thank you. And my follow-up question is very, very similar to what Rachel I see has got in the chat. It's so here, at least my experience where I practice, people are very hesitant to put in peritoneal drains
Mm.
until people are actually in hospice. They're worried about the risk for peritonitis. They're worried about some of the reduced immunity while someone's on chemo, if they're going to be getting chemo at the same time. It tends to be either you get your just bedside paracentesis until you do hospice, and then you get a drain
Mhm.
when you're in hospice. Does that tend to be the process also in Sweden, that these drains tend to be reserved for hospice, or do you guys use them more upstream?
Now I think we use the more upstreams.
Mm.
You have to. I think it's not a good thing to put it in too late, because then you're not be able to draw benefit of it. So, but you have to really think about it so that you give indwelling catheter drainage to the right patients. We the Our colleagues at the gynecological oncology department, they're quite, I think they're quite good at this. They don't suggest an indwelling catheter early in the trajectory, because they know that most of the patients they will the cytostatic treatment, it will make the ascites to decrease, and then you have a catheter that doesn't is used, that it will not be used, and you have to remove. So but I think uh, we here in Sweden, in Stockholm anyway, is we don't wait too long to put it in. It is not um, just pinpoint out to the hospice patients.
Mm.
Um, but in another way, I think the palliative care maybe is a bit other. Is the organization of palliative care differs, I guess, from your point of view. In our vicinity, we have the palliative home care team where I work. We also have we call it SPSV, specialized palliative care hospice care, which is in our language is it's similar to hospice. But I believe that in your area you differ this. between the specialized palliative care ward and the hospice. But in my vocabulary, this is the same thing. So um, yeah, I don't know if that's what's answer to your question, but
No, I appreciate it because I'm bringing this is all tied into what's going on in the chat right now as
yeah,
well. Because, I mean, Steve points out here that if we place these more upstream, maybe it impacts people not having to go to the emergency room so often and being
yeah,
able
that's
to
right.
stay at home.
Hmm.
And
Hmm.
that tends to not be as much of a focus here in the US, even though it probably
Yeah,
should be.
yeah. And you had another question about peritonitis, and yeah, I've experienced it quite a few times.
Hmm.
I have inserted like 50 or so Pertex catheters, and I have no real data of this, but my feeling is that uh, the few cases where we have been where the catheters need to be removed because of reoccurring peritonitis has mostly been when in liver cirrhotic patients, and my opinion is that they have a maybe they have a more poor hygienic thoughts about this. Um, maybe still alcoholic abuse, stuff like that. So they don't care for their catheter as well as the cancer patients do. And I asked the provider of the Peritex catheters in Sweden, and if you look at Germany, they put in a lot of catheters for liver cirrhosis patients, um, and I mean a lot, and they do not have that many peritonitis in there.
Hmm.
But I've talked about this to the liver doctors here in Stockholm, and they're not very keen on putting in Peritex catheters in their patients. I think due to this, um, the risk of peritonitis.
Hmm. There was a paper that came out this year taking a look at some of that. I think it was from France, though don't
Oh,
entirely quote me
okay.
on it.
Yeah,
But they were looking at this risk of peritonitis and showing that it
yeah,
incredibly low, like it's single digit
yeah,
percentages,
yeah,
and
yeah,
even in that study when they looked at the patients who developed peritonitis, a small fraction, like maybe 1 in 4, actually had to have the peritoneal catheter removed. Just antibiotics were
yeah,
usually
yeah.
enough, which, I mean, that's something
That is
you.
usually. I agree. It's usually enough. Yeah.
Okay. All right.
Mm.
Thank you. Sorry I hogged the time with questions.
No, it's okay.
Not at all. I don't see any other questions in the chat and or any raised hands. So if there are no further questions, I think that we will thank Johan for his presentation today. It was really helpful and informative. So thanks so much for being here. And we will give everyone the rest of their Friday back. Thank you so much.
Thank you for having me.
All right,
Bye.
take care.
Okay, take care. Bye bye.